Special thanks to Jeff, your organization, BHCG, the members of the Executive Steering Committee. It's a little wild to be up here. As some of you know, I'm from New York, and to be in front of a room with people, and for all of you joining virtually, it's hard not to reflect on what we've been through in the last 15 months. The clapping from balconies at 7 o'clock every evening in recognition of our essential workers and everything that they've done over the last year. The absolute ghost town of Times Square, no Elmo, no Rubber Band Man. And for those of you who know New York, the energy that comes from the quirks of New York is what makes it special. And so for this type of event to happen is personally gratifying for me. And I thank all of you for having me here today. So we have about 40 or so minutes to talk through the product launch. And we're going to hit 2 or 3 things. We'll hit why are we doing this? Jeff already has teed that up. We'll get into a little bit of detail just to cement what I think is the most important thing, which is that regardless of the right decisions for your organizations and where you want to take your health program, we must recognize that something has to give. We cannot cost shift any further. We cannot keep the status quo going any further. America can't afford it. And so we will offer a model that will help address that, but regardless, I would ask all of you, especially the employers, the business community, the purchasers in this room and who are joining virtually, make it a commitment to restore affordability of your health benefits to your workforce. They need it. We need it. The second is we're going to walk through the set of partnerships that we're proud to announce today with providers in the community and with other partners that will create access more broadly, both in the state of Wisconsin as well as outside. We're probably not going to have time for those of you who are going to have really important questions, such as the relativity of the maximum attachment point on our network versus others. So for those of you who have those kinds of questions, we love to have them. Matt Katz, we'll introduce him at the end. We will absolutely work through how to get to every one of those detailed questions, but today we'll probably keep it at a little bit of a higher level. All right, so what you're going to hear about today is obviously, as Jeff said, a build on what BHCG has been doing. You can see our shared goals. Very simple yet powerful. Easy to say, hard to do. Our role, I'm proud to say, is limited but important. Our goal is to be a catalyst. We are the least important stakeholder in this conversation. It's the purchasers, the business community and BHCG, and those providers who are committed to delivering value, not as a term on a website, but who have made the strides inside of their organizations to drive cost-effective, high-quality care. Those are the most important stakeholders. Our role is to bring that together to make it real so that organizations of all sizes in this community can absorb and implement. And lastly, as we've talked about, we commit to absolute transparency. Fees are important because the name Centivo is rooted in the word incentive, and to fix our problem in healthcare, we need to realign the incentives of healthcare. But beyond fees, we'll get into that as we get deeper into the conversation. One of the absolute minimum conditions from BHCG has been every employer that participates in this program has the right to know the raw materials cost that it pays for healthcare. There will be a level of transparency that's available through this program that has beforehand not been available in this market. So again, why are we here? All of us know healthcare is expensive. All of us know deductibles are too high. All of us know premiums have been increasing faster than the rate of wage growth throughout the country. As many have said over the years, open enrollment has unfortunately become the announcement of the annual pay cut in organizations throughout America. But I think the issue that is becoming increasingly clear is while we have tried multiple ways to solve and finance those cost increases, the impact it's having on everyday Americans is becoming so stark that it's becoming a public health issue. It is a public health issue. You can see some of the numbers here. The relative increase in spending on healthcare versus food and housing. The fact that almost half of America that has insurance, we're not talking about uninsured Americans, almost half of Americans saying they can't afford their deductible. Over half of Americans declaring that they have skipped or delayed medical care. We shouldn't tolerate this. in the year 2021 in this country. Now, it's easy to cast a lot of blame. There's a fog of war. Healthcare is complicated, it's been famously said. And it is. But ultimately, if you follow the numbers, the increase in costs, the lack of affordability, is in large part, yes, we're sicker than we need to be. Yes, we're a little bit overweight more than we should be, certainly me over the last 15 months. But the problem is not excessive utilization, the problem is growth in unit prices. This is something that's been studied over the years. It's been something that folks have talked about. It's something that collectively we have felt helpless to address. We've outsourced, if you will, the job of negotiating unit prices to large insurance carriers and expected that their scale would drive value. Here are the numbers. Those of you who have kids in college certainly know, don't need to be told that college tuition and books are going up. But aside from that, aside from college tuition and childcare, there is nothing over the last 20 years in America that has risen as fast as hospital services and medical care services. Unit price per unit of healthcare consumed. We also know, and Jeff alluded to it, that prices are particularly high in Wisconsin. Quality is very good in Wisconsin. We should be proud of that. But that doesn't mean that we can't do better on relative price. There are CEOs who are members of BHCG who are on the record saying, why aren't we paying closer to Medicare prices? Well, I think those of us who studied this problem would say, that's probably a bridge too far to go straight to Medicare. But on average, to be one of the top 10 states in terms of what we pay on a relative basis, and to be paying on average about 3 times what we pay Medicare, is also a bridge too far when it comes to the burden on the purchasing community. And the other quirk in the state of Wisconsin is the fact that, as you can see, in most places, facility charges are quite a bit more than professional costs. Not the case here. Professional and facility costs, both very high, one of only 5 states in which the actual rate relative to Medicare of professional services is greater than that for facility. Now, we've talked about quality is important. Ultimately, the reason we all have health insurance is for those unfortunate days and weeks and years when we need it. That's why we have any insurance. So we're not looking to ever compromise on quality. But those high prices have not bought consistency when it comes to quality. And this is work, again, that BHCG has been a leader and at the forefront of, working with GNS Health around the physician value study. And what it shows is that there's a $500 million opportunity in this community, a $500 million opportunity if we were simply able to get providers to perform A, at the level of the median provider, and B, steer downstream specialty care to those who practice at the median or above. $500 million. That can make a lot of deductibles and hardship go away. So yes, quality is important, but quality and price remain in Wisconsin, as it is throughout the country, not correlated. We can do both, and we can do better. So part of the problem, why do we have this unevenness? Why do we pay more and more every year as purchasers? Why has open enrollment become the announcement of the annual pay cut? Well, we overspend on healthcare, but we underinvest in primary care. Again, we all sort of viscerally know this, but when you see the data, it is stark. You see on the bottom, we spend about 5%, a little bit more than that, on primary care in this country. You see how that stacks up against hospital care, 7 to 8 times larger. You see that we pay about half as much as other peer countries, wealthy countries in the OECD. The lack of investment in primary care has led to the concept that Jeff described called medical homelessness. Other things, the millennial workforce, the transient nature of how we now live, the rise of urgent care, the rise of what I would call uncoordinated, disconnected telemedicine, have also contributed to this increase in medical homelessness. You don't have to listen to me. Last month, the National Academy of Sciences, Engineering, and Medicine basically said something that Kaiser and others have said now for 30 years. Every American needs a sustained relationship with a primary care physician. And oh, by the way, Back to the Future, they actually said we should default people to have a primary care physician if you don't have one already. We'll talk about how that works, the program design, because we know people hate having things done to them. But it's important that those who look at this problem and think about it generally agree that we need to solve the issue of 25% of people not having a PCP, and an issue that's even more acute amongst younger folks. Kudos again to BHCG for its focus on this issue and its continued activism. It's important regardless of the health plan solution you implement. So the other thing that gets a lot of press, if you read the newspapers or otherwise, is because of the holes in the insurance system, we have created a new safety net in America for medical expenses. It's called GoFundMe. How sad is that? How sad is that? The stock prices of the insurance carriers have gone up at a rate 10 times higher than the average American wage, and yet our colleagues are turning to GoFundMe to pay their medical expenses. Sadly, like a lot of things in this world, there's a whole bunch of high-profile campaigns that get fully funded. 90% of them fail and don't meet their goal. Maybe that's a good thing because we'll do better than that. And last but not least, to the extent that clinical outcomes matter as well, the data is becoming increasingly clear that those employees and family members that are affordability or wage sensitive not only are deferring routine care, but in many cases, according to this Health Affairs article, are deferring emergency care, severe care. The thought of the anxiety related to financial wellness and a lack of financial well-being is affecting healthcare outcomes. So what does work? It's worked in this state. President Obama stood a couple hours north in Green Bay 12 years ago and said, why can't we do things like we've done in Green Bay, like we've done with Intermountain Healthcare in Utah, like we've done with Kaiser? Primary care-centered programs, as Jeff alluded to, do work, and they've worked all throughout the country, including here in Wisconsin. And so with that, one of the questions that a lot of folks will ask is, a lot of this is going to sound really good. Why can't we do this with the existing players that we have? First of all, as I've shared with the members of the Executive Steering Committee, it would be a whole lot easier to go through that door. It would be less disruptive. It would feel like less change. I don't begrudge anybody at any of those companies, and I'm not going to say anything bad about them. But I would ask you this, as the business community, as purchasers of healthcare, if you had given a role to any of your business partners to hit an affordability standard for healthcare at sustainable costs, and there was a repetitive track record of failing for 20 years, would they still be on your payroll? Again, we can do better, and we will. So the way forward, our role is to be a catalyst, and we'll talk about what that means in this next section. But the catalyst is to bring together an engaged business community with high-value providers. We'll talk about what those words mean. It's a model that is not something that was dreamt up in a garage. It's rooted in principles that have worked, principles around high-performance health systems, principles around primary care, and principles around engaged and activist purchasers. Large employers have done this. Disney, Boeing, General Motors. Last week, the largest union in the New York metropolitan area, 32BJ, which represents all of the building workers, doormen, et cetera, who work in New York City buildings, announced that New York Presbyterian Hospital would no longer be part of their network. It is well documented that New York Presbyterian costs 2 to 3 times more than other systems in the New York metro area. Those are examples of purchasers having the courage to say, we can no longer afford high costs without justification. So what's the solution here in the state of Wisconsin, specifically in eastern Wisconsin? So as we've talked about before, and I love, Jeff, your term authentic, an authentic partnership, a partnership where we have said at the end of the day, for this to work, we need the commitment of the business community. And in order to commit to the business, in order for the business community to commit to us, we will commit in return. So this is a solution that is only available to members of BHCG. It's an end-to-end solution. We're going to focus mostly on the provider side of this conversation today. But other attempts to do things in this general area have often not been as successful because they've required somebody to piecemeal a solution. Let me find an administrator. Let me figure out a network. Who's going to do the care management? What about the PBM? What about the stop loss? There are a small number of highly enterprising advisors and companies willing to put those pieces together, some of whom are in this room today, and it's great to see the engagement. But most of America, as we've come to learn, needs to be able to pull this together in a program that syncs and works together, isn't assembled with duct tape and sticky gum. So the key parts of that end-to-end solution, building networks from scratch, built for purpose, centered around primary care and high performance. We'll share the partners in just a moment. Understanding that not everybody is going to want a plan that's primary care centered. Understanding that it is not comfortable for many employers, so there are a few considering it. It's not comfortable for many employers to look at their workforce and say, if there's a doctor that you like, they're at the bottom 50% of that GNS study, sorry, they're not available anymore. So to make broad access available both in the state as well as to be comprehensive throughout the country, we will bring options to the table that we will talk through. There is no configuration that is not available that wouldn't be appealing to any given employee and their family, given their own personal needs and concerns. Integrated partners in the areas of care management, PBM, leveraging the BHCG relationship with Navitus, stop-loss insurance, and a member experience to pull it all together. So as we've talked about, and as we've sort of given breadcrumbs around, how do you eventually save money? And my joke about maximum attachment points notwithstanding, we will work with all of you as the employer with your advisor in close partnership to make sure that you can prove that financial case to your team internally and otherwise. But ultimately, the financial case is remarkable. It goes back to following the data. When you follow the data and focus on high-quality providers who steer the right way and take out inefficient sites of care, there is a remarkable amount of money to be saved, as we showed you with that $500 million opportunity. The 4 ways that we attack this problem are using data to find the top providers, negotiating competitive unit costs, making sure that primary care steers in the right way, and referrals that are based not on personal relationships, but on data and analytics. And the result of this is you take that average American, $26,000 being spent for the family of 4, about 60% of that financed by the employer in terms of what the purchaser spends, about 40% of that coming from the employee, $10,000 per family of 4 when the average American household income before taxes is $60,000. Crazy numbers again. When you run through these models, typically we find about a 30% savings for the family, 15% or more savings for the employer, and that savings flips the script on the open enrollment announcement to, instead of it being a pay cut, the opportunity for a 5% wage increase. Big numbers are available, but as the old saying goes, if you want something to change, you've got to change something. Some examples from other markets and other work we do. I won't go through all of the numbers, but the numbers I'm most proud of, why we started this, why we felt there was a need for a catalyst between aligned high-value providers and the purchasing community, are the numbers on the right. What those of you who do this for a living would call actuarial value. Our average plan is about a 92% actuarial value. There are substantial cost savings opportunities. You can see they range based on where a company was, based on their claims, more cancer cases, less cancer cases. Those will obviously change based on those results. But back to the goal of affordability, regardless again of what you do as employers, I urge you to set goals, actual goals. What does it mean to have an affordable, cost-effective health plan? Actuarial value of 90% is a good number to me. You guys should choose your own based on your own organizations. Okay, so now for the grand reveal that everybody's been waiting for. So what were we commissioned to do by the Executive Steering Committee and by BHCG on behalf of the business community? Ultimately, we've covered some of these things, but number one, best in market contract terms. Through these relationships, there won't be a financial disadvantage going backwards, and in many cases, a strong advantage when it comes to three things. Number one is basic rates. Number two is moving more compensation out of fee-for-service into value-based programs, per member per month type compensation, rewards compensation tied to clinical outcomes and quality. As the employers we asked told us, we would be happy to pay what we're paying as long as it's actually tied to value. No different than we pay our own associates in our companies, base and bonus. And then thirdly, moving more of the contracts into bundles, episodes of care payments, fixed rate payments. Changing how we compensate for healthcare in Eastern Wisconsin. That's column one. Column two is recognizing that everybody in this room and who's joined virtually and beyond is going to be coming from a different place, has different goals and different thresholds for change. So there's an ultimate of flexibility in this program. Examples of that flexibility: the program can be offered as a side-by-side choice with your incumbent administrator. It can be offered as a full replacement option. There's flexibility around primary care center plans and non-primary care center plans. There's flexibility around open access options and broad networks. And there's flexibility because it's your health plan as a self-funded employer. It's not our health plan, it's your health plan, it's your money. You decide the terms and specifics of benefit design and plan provision in consultation with your advisors. And we've talked before about transparency and incentive alignment. Okay, the network options that are available through this program, so setting aside if you retain an administrator for a moment. So there are three network configurations, three flavors of high performance networks. To use normal, plain English straight speak, one of them is narrower, one of them is broader, and one of them is Goldilocks, sort of intermediate. All three of those have built into their networks and the contract terms the requirement for a designation of a primary care physician and rewards that are tied to the primary care physician being able to make more money as long as they're meeting the goals of the employer when it comes to high quality care, cost control, and guidance to appropriate care. You're going to hear more about that on the first panel. And then we're proud to announce that the solution is not complete with those directly contracted options alone. So we've partnered with HPS, and thank you to Tom and Terry in the room for the partnership that you've had, and we look forward to building and growing it. HPS is a trusted brand in this market, critically amongst providers. And through its financial strength, we will have the ability to offer an open access option here in Wisconsin that is extremely market competitive. And for those of you who have associates throughout the country or in the era of a post-COVID world, think that you may be hiring more outside of this area, we have a relationship with Cigna, which will create a national access plan for any associate. So with that, primary care guided options, open access options, multiple configurations to best meet your needs. Excuse me. So Wisconsin 1 is the, let's call it, the broadest configuration. And we're proud to announce that the two largest systems in the region, Advocate Aurora and Ascension, are both partnering to be participants in Wisconsin Configuration 1. In addition to that, the leading academic medical hospital, as well as strong partners from a coverage geographically, clinically, and independent perspective with respect to ProHealth and IPN. This is a network configuration that, again, assuming a typical commercial claim distribution, we project close to double-digit cost savings while retaining the majority of access that an employer group and a member may need, including brand loyalties that are powerful, as we know, in this market. There are additional systems and conversations that we're having on a daily basis, and so I would fully expect this list to grow over the course of the year. But these are our anchor partners for Wisconsin One, and we thank them for their commitment to the business community and for stepping up to be leaders in value-based care. Wisconsin Two is a slightly narrower configuration, and as you can see, drives potential cost savings. And Wisconsin 3 is the most cost-effective solution that may, for some employers, be the way to drive value-based care to its strongest, most high-impact way. And ultimately, each of these networks can be deployed, and this is where the role of the consultant comes in, on a side-by-side basis to offer as little or as much choice with the primary care-centered options as you would like to see. We have some employers who are looking at this to offer 2 of 3, maybe 3 of 3. We have some who say we're going to keep what we have, but we want to offer one of these. That's entirely up to you. But ultimately, I think the key message here is that the provider community has stepped up to meet the needs and the urgency of the business community. It's something that 6 months ago we may not have been able to predict, given the strength of the status quo. But I think it speaks to the fact that the thirst for change is high, not only amongst those who are suffering from out of control costs and lack of affordability, but amongst providers as well, who are looking to get credit for the value that they're delivering on a day in and day out basis. So as we've talked about, you have the flexibility to keep the plans that you like, as famously said. In this case, it's employer-driven, so you absolutely have that. Or the ability to completely replace your plan option with a single administrator. We can talk through the pros and cons of that option. But the benefit of the full replacement option is, in addition to having a single platform for all of your benefits, a single platform to house your analytics, your reporting, full transparency across plans, you have the ability to get the benefit of the relationships with HPS and Cigna as well. So again, many of you are already familiar with HPS, but we're very excited to have them as part of this. Again, nearly 25,000 contracted providers, extremely competitive and favorable discounts that have led to below market trend, experience in data, and a degree of trust with that provider community. Critical to everything we've been talking about is transparency and trust. And it was important to bring partners to the table who share those values, and we definitely feel that we have that, and some of you who are clients today of HPS know that from the way they operate. And lastly, again, in the year 2021, we know that you can't go to your leadership and say, I've got a great solution in eastern Wisconsin, but we're going to let our colleagues in Nashville fend for themselves. Unfortunately, it doesn't work. So excited about the relationship with Cigna. Some of you, especially in the consultant community, knows that Cigna has a longstanding relationship with third-party administrators like ourselves. The unique part of our relationship is the ability to have our own directly contracted relationships and options like HPS in the mix. In addition to the ability to get what other administrators also get with Cigna, which is the logo on the ID card, national access, and the ability to use their financial arrangements. So ultimately, every employer and their advisors have 3 decisions and some recommended guidelines. And this is going to be the start of a conversation. So we're sure we're going to have lots of details to work through as we look at maps and censuses and disruption and access and all the things that we're ready and excited to do and have already started to do. So the first is, do you want to add to or replace your current plans or carrier? The second is, choose your network. 1, 2, 3, more than one. It's up to you. Some of the consultants are getting really excited. It's like Play-Doh. Get to really work on this in a way that you like to. And then lastly, choose your plan designs. I kind of rolled over it, but we have, I showed on a previous slide, copay-based plans, HSA qualified plans that are PCP centered, and then of course you can choose to run open access plans the way that you like. Again, I want to emphasize something. If you're a self-funded employer today, you may have made decisions already on what we in the industry call page 2 through 99 benefits. Those are your decisions, not our decision. If you're a fully insured employer and you haven't had the ability to make some of those changes, you'd like to explore the flexibility that a self-funded program can bring you, talk to your consultant, talk to your broker, have them talk to us. There's tremendous advantages to the transparency and the flexibility that comes from a program like this. From the perspective of the partnership plan, the PCP guided model, some recommendations. Ultimately, it's your plan, you control the pen. But what we've done in other markets that have worked extraordinarily well, that have driven those affordability results that you've seen, in addition to the cost savings, are number one, a fair contribution. We don't think necessarily it should be the cheapest plan, especially if you have a very high deductible, but a fair contribution that recognizes that the systems who are participating in this product are offering rates and terms that deserve to be priced in a way that reflects that. Number two, the removal of the financial barrier around the deductibles on the PCP copay-centered plans. Thirdly, free primary care. If you were listening about 25 minutes ago, I think we talked a lot about primary care. One of the things that we've learned is the power of the word free. When we've talked to members, when we've done some feedback, again, the principles of this are not new. But I think the context is. The context of reintroducing a plan design that's centered around primary care and makes it free, coming off of an era where we have cost shifted for 20 years, we found something really important. It reinforces trust that the health plan works for them. It reinforces the idea that you shouldn't be ashamed to use your health plan. That this isn't about watching your HSA balance and seeing if it's going to go up like an odometer. This is about getting the care that you need. It's about not having to wonder if my kid's earache is actually an infection or something worse. And making primary care free is a small price to pay. What we've seen in our data is that we spend about 30% more on primary care, about 1.5 points on most employer plans. And the return on that is anywhere from 5 to 10x, depending on the employer. One of the most shocking developments, in a positive way, has been that we've seen the increase in preventive care, well visits. They've been covered for 12 years for free. We've seen preventive care rates of utilization go up by 50% or more. Why? It was already free. Because America has decided that if I go to the doctor and they find a mole or some code was issued as part of my visit, that I'm going to get a bill, and I don't trust any of this anymore. Making that site of service and that experience free rebuilds trust in the plan, rebuilds trust in the clinician. That's how we're going to solve this problem together. So just a couple more things and I'll wrap up. Promoting the relationship that BHCG has with Navitus, it's an interesting story. About 3 years ago, as we were going through our journey, we determined that the right way to deliver pharmacy benefit management services is through fully aligned, fully transparent partners that only work on administrative fees, that don't benefit from what's known as spread pricing in the industry. That's a topic for another speech at another day. But the point is, we independently surfaced Navitus and the work that they do based out in Appleton. BHCG came to the same conclusion. And so we've actually brought our programs together, where all of Centivo's business goes through the Navitas program that's been established by BHCG, benefiting all parties. A real win-win because of the power of what they do. And importantly, any new member to this program gets the benefit of the 60,000 covered lives that are already going through this Navitas purchasing program with BHCG. So I'm going to skip, because I've hit a lot of these points. We'll find the right way to share these. We have some good case studies around employers that have done this on a full replacement basis, but I think we've already hit the highlights of the results. Same thing for those who've offered on a side-by-side basis. Again, this is one of my favorite stories. This is a large national employer, global employer, 20,000 employees in the US, global 150 employer that most of you have heard of. 97% of their associates activated the primary care physician before the plan year started. And so far, that's the example I shared with you, 96% of expenses paid by the plan. Remarkable story on the restoration of affordability. So what now? We probably need a more updated photograph from what I'm gathering. But Matt's over here for those of you in the room. Feel free to reach out to me. Feel free to reach out to Jeff, other members of the BHCG team, the Centivo team. But ultimately, I'll leave you with this message. Our work here is entirely at the pleasure of the business community. We are here for as long as you want us to be. If you ask us to leave, Jeff, we'll leave too. But it's not our goal to create something that is a Centivo product. It is our goal to be a catalyst for change and hopefully see some of these results when it comes to affordability and cost sustainability in healthcare here in Eastern Wisconsin that we've seen elsewhere. Thank you.
So, Ashok, I'm wondering if you could provide some clarification on your comment on the additional systems in progress. And I think the way you phrased it is during the course of the year, but many of those agreements with health systems and provider groups are going to be finalized in short order?
Yeah, absolutely. So I think one of the things that we've observed through this process is this notion of direct contracting. Some of you in the employer community and the consultant community, you've done some of it yourselves, you've had some exposure to colleagues in other parts of the country that have done it, but it can be like a development of a new muscle when you play a new sport. And so what we've learned from the provider community is everybody believes in the mission. And I believe that the other logos that you may not have seen that you are expecting to see, we welcome you to be part of this, and I fully expect that to happen very quickly. But I think as we've come to learn that there is sometimes some re-education about what does it mean to directly engage the business community? What does it mean to engage with a player whose charter starts and ends with full transparency? What does it mean to engage with a player who ultimately is only focused on the value that we can bring to that tandem of the business community and the high-value provider? So as we work through that, we will have more logos up on that slide, and certainly it will be a different-looking network than a traditional one. Back to my saying, if you don't change something, nothing will change. But there are some continued conversations with key entities that we expect to have done very soon.
Additional questions from those of you in the room, please step up to the mic.
Good morning. Skylar File from the Benefit Services Group. I'm curious if companies that have a national footprint and are operating in locations where Centivo also has relationships, if there's an opportunity to access this model, the direct primary care model in those those markets?
Yeah, it's a great question. So I think everyone heard it. The microphone's working well. So we expect to be, in addition to Eastern Wisconsin, up in about 16 MSAs by the end of the year. The closest one where we're live today to Eastern Wisconsin is in the Iowa market in Des Moines. So whether it's that, Southern California, Florida, other parts of the Northeast, that would also be accessible. So that's correct. And then the other thing that we're working through from a detail perspective is how to simplify that member experience. So regardless of the network configuration you choose, one of the features on the HPS platform is the ability to have a common, simple explanation of benefits. And so we're looking to have that apply across the board as well.
I have a question about the basis that you used to calculate the savings that you showed up there for the different options. Were you able to get actual data from employers in the coalition through United Healthcare, sanitize it, run it through the system, and sort of reprice it?
The good news is we have the chief actuary who did the work. So Dave, I'm going to call you up to answer that question. But it's been, I know, painstaking work to compare costs on a unit basis and from a care redirection perspective.
Must be a tough question when you drag the actuary up. So yes, we've got a ton of data that we've used to really look at relative pricing terms. We have a lot of competitive information on existing rates in the marketplace, including UHC level rates. So we've been able to use that from a comparison standpoint. We have received a significant amount of information from employers that are directly looking at this, and so as we do value proposition for those employers, it is based on their actual information, and we can take the data that we have and calibrate it to the employer situation. And then as we look at the expected change in how and where care is provided, we have a substantial book of business on the Centivo side that looks at how, in this case, a primary care center model really does change care. One of the things that we think is really important for you as employers and you as advisors and consultants to your clients is to make sure that we have articulated that completely so you can see where the numbers come out. And so, Ashok showed your slide that said, here's the 4 buckets of savings. When you see a value proposition from Centivo, you will actually get those 4 buckets of savings so that you can explore it, you can kind of push and prod on it, understand where all those numbers go and really get down to the detailed level. And then again, as Ashok noted, to the extent you want to understand the actual contract terms that exist with the health systems in the state, you do have access to those. So this is, as we've noted earlier, a significant transparency effort. You need to understand the numbers. It's not a situation where we're going to come to you and say, oh yeah, here's the savings. It's 7 to 9%, it's 14%, it's a number. You need to see where those savings are coming from. That's our commitment back to the community.
Thank you. Other questions? Stay close by, Dave.
No numbers question.
Phone a friend.
Just curious with the chart of the local systems that we saw, wonder if you might be able to comment why they might be willing to provide better rates to Centivo versus the Uniteds and all the big players in the market. Curious.
Yeah. So I'm going to give you a high-level answer, but we have a panelist from one of our partners, and certainly, while the focus is clinical, that's a question that's reasonably addressed to him as well. What we've seen in multiple markets, not specifically to Eastern Wisconsin, is that providers who have self-organized to deliver value feel like traditional broad networks for service reimbursement is not reflecting the value that they're bringing. What does that mean in real numbers? What it means is that an organization that has shown the ability to deliver cost of care at 20 to 30% below, when they're participating in a network with other players that don't share those same outcomes, what happens is, for those of you who underwrite, is a blended premium or a blended premium equivalent type of situation where, ironically, the high-value players are subsidizing the low-value players. So the business imperative, this is certainly not, and I really appreciate the question, because this certainly is not a, boy, Centivo has more members than name your carrier, but it's a recognition that the type of patient volume, employees of employers, the reduction in bad debt and collections from the plan design that we shared, and the ability to actually participate in a network that is only constituted with those parties who are committing to these value-based principles, that meets their business needs. So the rate is a reflection that this is better business for them. The other thing that we've come to see, again, in other situations, as the pricing transparency data is now becoming increasingly available, the unit cost conversation has far more to do with these sorts of principles around what is the relative value of those patients to our system, and less about the scale of any one of those players. So it's a really good question. We should continue to sort of explore that in the panel, but it's something that we have seen now with remarkable consistency in every market we've operated in, including here in Wisconsin.
Can I comment on that?
Yeah.
So as Jeff said, in one of my prior roles, I was in Orlando Health, and in the strategy role, we oversaw a lot of these contractual negotiations. And so I think you hit on all the important concepts from the economics for the health system. But the thing I wanted to comment on is, where you said give it to Centivo. And our partners, we really emphasize this isn't a rate to Centivo, it's a rate to the employers in your community. And so that really resonates with the health systems. Like, hey, if money is saved, it's not going in some carrier's pocket, it's going to that employer and their employees. So I think that's just, and that really, so I've done a lot of the work with our health system partners, and when we say that, it's like, you know what, that's right. You're not giving a rate to Centivo that goes into Centivo's account. It goes to those local people in your community, and I think that's a key point.
Jeff, should we wrap up, or?
Time for one more question. If not, thank you, Ashok.
Thank you.